Tanvita, are you ready? You're ready? Yeah. Yeah.
A very good afternoon to all. I'll be presenting on cavernous sinus syndrome presenting as a mononeuropathy. So the objective of our case series was to describe clinical profile, presentation and outcomes of patients with cavernous sinus syndrome presenting as a single cranial nerve palsy. As we know that cavernous sinus syndrome can present as a multi-nerve involvement with the third, fourth, sixth and the first and second part of the fifth cranial nerve. So we went ahead with this analysis where we conducted a retrospective analysis over a period of 1 year at our center. We included patients with acquired mononeuropathy who had radiologically proven cavernous sinus lesion and excluded those patients who had congenital neuropathies or any other cause of mononeuropathy like ischemia or trauma. Further, data was collected of the demographics, vision assessment, strabismus, motility, their lab workup, neuroimaging findings, treatment and outcome at presentation and at follow-up. We found that in our study period, we observed a total of 287 cases of isolated third cranial nerve palsy and 386 cases of isolated sixth cranial nerve palsy. Out of these, 4 patients met our study criteria, who were all male, with a median age of 41 years. Left eye was seen to be more commonly involved than the right. One of the patients had a coexisting diabetes mellitus, which was diagnosed when the patient presented to us. At presentation, all these patients had the complaint of diplopia and that they were unable to move their eye. 2 of these patients also had pain on eye movements. There was no neurological complaint in any one of them. 3 patients had the involvement of the sixth cranial nerve and 1 had the third cranial nerve involvement. All of them presented with the best corrected visual acuity of 20/20. The anterior segment examination was normal. All of these patients presented with a single cranial nerve examination, except for 1 who eventually, after 3 weeks, developed reduced corneal sensation and hyperesthesia of the trigeminal nerve. The rest of the cranial nerve examination was normal in all of them. So we had ordered an MRI brain with contrast, and after getting diagnosed with cavernous sinus involvement, these patients underwent chest X-ray, MON2 test, serum homocysteine, serum ACE levels, blood sugar levels, lipid profile, a complete blood picture, and the ESR count. It was seen that 2 of these patients had come positive for MON2 and were presumed to have extrapulmonary tuberculosis. One of the patients was having diabetes and another patient presented with hyperlipidemia along with hyperhomocystinemia. All of these patients had cavernous sinus involvement and one of the patients even had the involvement of the orbital apex. On MRI brain with contrast, we could see that there was a bulky enhancement of the cavernous sinus and with the orbital apex involvement in one of our patients. So further, diagnosis of mononeuropathy in cavernous sinus syndrome was made with an etiology of presumed extrapulmonary tuberculosis in 50% and while that of idiopathic in the rest. So the 2 patients who were MON2 positive were started on ATT, followed by starting oral steroids 1 mg per kg after 2 days. The patient who was a diabetic patient did not have any aneurysm or pupil involvement and was started on oral steroids by their neurophysician. The last case was lost to follow-up eventually. As we can see that all of these patients showed drastic improvement over 1 to 4 months. The main limitation of this study was that it's a retrospective analysis with a small sample size and a short follow-up. But I would like to conclude that cavernous sinus syndrome or orbital apex syndrome may also present with an isolated mononeuropathy, and this could actually be the first presenting sign. It is imperative to investigate the underlying etiology in these patients and not to treat it as just a presumed microvascular ischemic cranial nerve palsy, even though other vascular risk factors may be present. An appropriate and timely treatment in such condition will have favorable outcomes. Thank you.
Did you compare with different any other studies or case reports which are there?
There are single case reports, ma'am,
Yeah.
but not a combined study or anything that has been seen yet to show mononeuropathy in a cavernous sinus syndrome or an orbital apex syndrome.
So, what other things radiologically do you see that you can conclude, because yours was idiopathic or tubercular,
Yes.
nothing else? So, what are the other signs do you get when you see from radiologically that you can say that, or you can say it will be going towards that?
So if we have granulomatous lesions that are present at the cavernous sinus, that could go to a granulomatous type of cause like tuberculosis. That can be seen. And
Granulomatous is easier to diagnose as a
Tubercular,
meningitis.
yes.
Other than that,
we can see if there is any
because
increase.
you have done the study, so
Yeah.
you must have seen some other features which is coming up. That is
Ask
what
her
I
to
want.
speak on the mic.
As they were diagnosed in a very early stage, most of them presented with just the cavernous sinus bulky granulomatous lesion that it started with. As they were started with ATT earlier only, we did not see any progress because the neurologist had done repeat MRI in these patients over 3 to 6 months post starting ATT, but they turned out to
But
regress.
the patients are presenting initially with a mononuclear
Yes.
palsy to you.
Yes, yes.
So you must have advised for a
MRI.
scan. So,
So-
what did you see? Those findings I just want to know.
Okay,
What are
so-
the different findings did you see?
So, if these patients did not improve as a mononeuropathy within the 2 weeks, if there was no improvement at all, then we had ordered for an MRI, and in them we had found
So you
to
only saw granulomatous.
only
nothing else?
granulomatous, nothing else. Yeah.
I think it was a very nice presentation and very
Thank you.
interesting study also. But
Thank you, ma'am.
what I wanted to know was how many, what type of neuropathy did you find? How many complete ophthalmoplegia and how many you had? both,
Yes. So the
partial?
sixth nerve that we found, all of them were complete. The third nerve was pupil sparing, but
all of them were pupil sparing?
yes, all of them were pupil only one patient had third nerve involvement, which was pupil sparing, and the rest 3 had sixth nerve involvement, ma'am.
Okay. So, and also you had one patient with diabetes.
Yes.
So, how would you how did you differentiate? It could be due to diabetes also.
So that patient was having, like, he
Maybe
got
a
diagnosed.
incidental, finding that
Yes.
you're having a cavernous sinus.
Probably because that patient was found to have diabetes with us only. He was not a known case of diabetes before. So when the patient was not improving over a period of 3 to 4 weeks for him, we got an MRI done, and then it came out to have a cavernous sinus involvement in him.
Thank you.
Yeah.
Thank you.
Yeah. A very good presentation. I just wanted to know, is it possible for you to tell me the anatomy of the third nerve from nucleus till the muzzle?
Sure, ma'am. So the
From
third nerve
where does it-
arises from the midbrain, and it goes through. It descends through in between from the red nucleus substantia nigra, and then from between the PCA and the MCA, it comes down, and then it enters into the cavernous sinus, and after that goes to the orbital apex and enters into the eye, where it divides into the superior and the inferior branches to supply.
Yeah. And that was exactly the reason why the pupil was spared.
Spared, yes.
Good. Very good.
Thank you.